All right, so now we're going to be talking about an autoimmune disorder called MS, or multiple sclerosis. And a lot of you guys have taken care of patients with multiple sclerosis. So first thing we have to do is we have to break down the pathophysiology of what's going on with this patient. So if you break it down, sclerosis, so we have like scar tissue, okay, and inflammation happening in multiple spots. Now, we know with MS that what we have happening is we have, again, it's an autoimmune disorder, so it's our self making these cells that kind of Pac-Man away at this myelin sheath, all right? So these little guys are doing damage to the myelin sheath, which is wrapped around our nerves and that conduct messages to and from the brain and to the other parts of the body. So what's important for us to understand is that as they attack that myelin sheath, it causes scarring. Just like anytime you get a cut, same healing processes, right? There's swelling, there's white cells, and all that stuff gets dumped in there, and then there's scarring as it heals. And so they go through multiple systems with that. That little guy was driving me nuts because he was backwards. So, but they're just kind of constantly munching and eating away at that myelin sheath. And depending what type of MS they have, depends on kind of the fluctuations of it. MS is a very individual illness or autoimmune disease, okay? So two MS patients are not gonna look the same. What we do know about it though is that other than it's autoimmune, okay, we know that it usually hits people between their 20s to 40s. So think about what you did today. If you're within that age range, think about all the activities you've done today. If you had MS, how would that impact your day? How many times have you driven your car? Would MS, if you were not able to move that hand as well, would that have impacted that? So kind of just take a second to step into their shoes and the different ideas of what's going to be going on, right? So that nerve may or may not ever fully heal, and they may have continuous problems. The other thing we know about it is that it affects females more than males. Okay, and that doesn't mean that guys can't get it, but it does mean that we see it more often in the female population. So it's something that, like, this is probably the one illness that for me is my, like, oh God, don't tell me I don't want MS. Like every time I'm like, I get some numbness in my hand, I'm like, oh God, I've got MS. I don't have MS. I just have slept on my arm or something. But those are kind of the things. So let's think about some of the signs and symptoms that go with MS. Now, remember, we're talking about nerve conduction. Oh, let's use a different color marker here. We're talking about nerve conduction. So nerves impulses come through and they go, say, to your foot or whatever. So we've got our brain here and we've got our foot down here. Well, if you've had enough damage from these guys munching away at it, right? They've just kind of chewed up on that myelin sheath, caused all sorts of swelling. Now you've got, it takes longer for that nerve conduction to get through, if it can at all. If they've completely damaged that nerve, it's not going to get through. So then you can think about your signs and symptoms are going to be a lot of stuff that's very nervous system in nature, okay? One of the first things that people will have is vision issues. It gets the nerves of the eyes. Other things that they'll have, fatigue, okay? Fatigue or weakness. They also have that numbness and tingling, okay? Balance issues. So hard to stand. I know one time I got all panicked and paranoid. I had been trying on shoes, and you know, like any girl, I can try on shoes with the best of them. That's the one thing that fits so nice that just makes it easy. So but I was trying on shoes and I had to keep stepping, 1 foot to try on a shoe or whatever. And all of a sudden I'm wobbly and I'm like, oh my gosh, what's going on? And I noticed for a couple days that my balance issues were it. I wasn't having balance issues because I had MS. I was having balance issues because I had some vitamin deficiencies that I needed to correct. My diet is not the best, which I know. So that's why a lot of these issues, people could go on for a while because they don't know that that balance issue is really a problem. They think, they can just blow it off. Maybe I just need to get more sleep. So other things that they might have is some bladder problems. Okay, might have some bladder incontinence issues. If all of a sudden you're 28 years old and you're having some incontinence issues and you haven't had incontinence issues before, that's going to make you kind of wonder what's going on, right? And they also might have some cognitive issues, right? Because again, these nerves are from the brain all the way to our feet. So all of a sudden they're having some cognitive issues. What do you think are the 2 issues that are going to bring people into the doctor usually pretty quickly or most often? Vision and bladder. Those are the 2 things that are going to bring people into the doctor. Again, balance issues. Maybe, maybe not. Maybe I just didn't eat real well today. Fatigue. I don't know about you guys. I'm a mom and a teacher, and I am almost in perpetual state of fatigue. Weakness. Well, I'm definitely not as strong as I used to be. Maybe I need to work out more often. Numbness and tingling. Well, sometimes your foot gets a little tingly. You sat on it for too long, whatever. Again, these other ones can kind of be written off by just personal choices and that kind of stuff. So not usually what brings us in unless we're falling a lot or all of a sudden we can't feel our hand at all. Fatigue, somebody else might notice it and be like, hey, you're just really tired all the time. You really need to go in and see the doctor. And that might bring us in. Cognitive issues. I mean, if you're really having some big cognitive issues, otherwise, again, well, I'm tired, so I'm having cognitive issues, or I'm just feeling overwhelmed and overloaded, so I'm having cognitive issues. So that's not something that necessarily is like earth-shattering for us. It's just like, oh, I just have a little issue I need to work with. So that's something that we got to pay attention to. But vision and bladder are the 2 things for our MS patients that are going to bring them in. What I want to talk about now is there's kind of some different types of MS that we want to look at because, again, everybody's MS is unique to them. It just depends what those little Pac-Man guys ate and the damage that was left on those nerves. But there's some really interesting when we're talking about the trajectory of the illness. And what we talk about is there's 4 main types of MS. And the most common is relapsing remitting. Okay, and this one is where someone, so here's like baseline, right? And they go baseline, and then they have what they call a flare. Okay, they have this flare up of having issues, and then it kind of goes, I need to draw better. It kind of goes back down, and again, they're back at baseline. And then they have a flare up, they get a little worse this time, but maybe their baseline just changed now. So now instead of being able to come all the way back down to this baseline, their baseline changed to now this because those nerves are now permanently damaged. Then maybe they have a flare up, maybe this one's not too bad, and they go back to this baseline. And they come here and, oh, that was a really bad flare up, and now guess what? They're back to this, or, where they lost more ability, more nerve function. And this is relapsing remitting. So they have a relapse where they have a flare, and then they come back down. But at some point in time, as that happens, their body is slowly going to have these problems, and it's going to slowly get worse. So they're going to have another one, and maybe that one doesn't come back nearly as well, and they have another one. And so you can see this kind of stair step up. That's relapsing remitting. This is the most common type. The other kinds, there's primary progressive. Oops, that's an I. Okay, primary progressive. And primary progressive is just constantly goes up. Like once they get it, they're just constantly, they never plateau again. They just kind of continuously go up. There's that damage to the nerves is just continuously happening. There is secondary progressive. Okay. And this one is, they have kind of some issues. It's always going up, but then all of a sudden it switches into that kind of full gear where it just goes up. That's considered what they call secondary progressive. And you know, they have that, I think maybe they have relapsing and remitting for a little bit, and then it turns into this. And then the last time is progressive, what do they call it? Progressive relapsing, right? Yep. I had to make sure I had the right notes because this is kind of specific to this. Progressive relapsing. And so it's kind of a mix of relapsing, remitting, and primary. So they have flare-ups, but they never go back to the original baseline. So these ones are more of a direct stair step. So again, that change, that damage to the tissue, that damage to the nerve is constant and chronic, like these guys. But this one, you could have time in between where you're fine. And these times in between, they could be 6 months, 3 months, 4 months. You know, this time could be a 6-month period where they have no symptoms and they're completely fine. Or they go into something where, you know, they have it every 3 months or something like that. So it just kind of really depends. You could have somebody, if they've had it a flat or a plateau for a year, they're considered, I think, like remission or kind of stable. They usually that year mark is good for them to get. But usually they're going to have several different flare-ups throughout the year. And that's going to cause a lot of stress on their body. How are we going to diagnose this? Well, it's hard to diagnose. The basic way we're going to diagnose it is an MRI. When these scar tissues happen to these nerves, right, to the myelin sheath, when that scar happens, you've got to get to an MRI so you can see those really small, they develop like plaques. And so there's just things they can see on there where there's just that white, hard solidified stuff where they can see in the MRI the plaques that develop. So you're not going to see this on somebody who's had their very first flare-up. But remember, most people aren't coming in for that first flare-up because those symptoms can be so vague in the beginning. You're not coming in until you've had several flare-ups and like, man, you know, 6 months ago, I remember just not being able to get out of bed and being so exhausted and whatever. And now I've got this happening again. That might cause people to go in. But that MRI takes a while to be able to see that scar tissue. Otherwise, it's really ruling stuff out and maybe looking at some lab values to see what else is possible that's causing this. Making sure someone's not having a stroke. Because a lot of these things happen very quickly and then slowly come back down, and then happen very quickly and then slowly come back down. So, I mean, it can look like a stroke. It can look like other things. So we have to make sure it's not something else first. Our treatments for this stuff, let's see, I haven't used red. Our treatments are going to be like what they are for most autoimmune disorders, right? For treatment, we want to decrease the immune system. That is the main goal, is we want to decrease that immune response. So treatments that we're going to use, steroids. These guys, when they come in, especially if they come into the hospital during an acute flare-up, we're going to be dumping a lot of steroids in them because we're trying to bring down that immune system response. We might do some chemotherapy meds to try and kill some of those antibodies that their body has made. We might be trying some chemo to try and break down some of that so that they can go back to a normal life. We have a lot of biologics that are coming out, and I'll be honest, like when I did home infusion as a nurse, I gave a lot of these kinds of meds, and it was like Tysabre, and I can't even, like Remicade, all these kinds of things for a lot of autoimmune, and it feels like every year they're just coming out with so many more. So the biggest thing for you guys to understand is that the goal of care for any autoimmune disorders is we've got to decrease that immune response, and then we're going to also be doing symptom management, right? If they're having pain, we're going to give them some pain meds. We got to do symptom management and take care of the side effects of what's going on, or the side effects of the medication. So our biologics, back to them, like our interferons, So there's A and B interferon. That's kind of one I've seen a lot going on there. And then we talked about the symptom management. You're going to have some anti-inflammatories. Okay. You might have some pain medication. Okay. So those kinds of things to help treat those issues. Think about, as a nurse, if we're giving people steroids, chemo, and these biologics, what's that going to put them at risk for? So we're decreasing that immune system, but then what does that put them at risk for? It puts them at risk for infections. It puts them at risk for catching viruses, catching different things that are going on in the world, or catching, colds from their kids or something like that. Like, it really decreases, when we decrease that immune system, it doesn't know how to decrease it for one thing and not decrease it for another. So when you're decreasing for that immune response, period. That then puts them at higher risk for some infections. So that's kind of the basics of, digging into this. But what I want to talk about next is I want to talk about, and there's going to be 2 pictures that show up to try and talk about the difference. Because remember, this is a spectrum. This is not, a one size fits everybody kind of disease. So it's a spectrum of an illness, right? So you're going to have 2 patients that I'm going to show you a picture of. Oops, that does not look like an arrow. Okay. There we go. And so down here is your person that's walking and talking and doing everything normal. And here is your person that is probably close to death, because MS does shorten people's lives. It does kill people eventually, because slowly and eventually, what do you think happens? What do you think happens that causes this? It's the inability to swallow, aspiration, those lungs. Once those lungs start getting impacted because of the nerve damage, that's when we're going to start seeing problems with and start going towards the end of life issues. So, or just their body is so weak that it then causes all those kinds of issues. But I'm going to show you 2 patients. There should be one here and one here. And I want you to think about, where are they on the spectrum? Are they, walking and talking, or are they closer to this? It's a spectrum illness. And again, one size doesn't fit everyone. So I want you to think about that. And as you're doing it, I want you to we talked about those priority care maps or priority concept maps. Think about, what kind of priorities are you going to be putting patients in? So if we talk about MS in the middle, how are these priorities going to change? So probably first, we're going to have immune as our first thing, whether it be because of the infection risk or it be because the disease itself is an autoimmune disease. Then, depending on where they are, you could say coping. If you've got somebody who's close to here and has little kids, coping might be your biggest priority, because how are they going to get their kids to school? How are they going to work? How are they going to do that? Remember, because these are 20 to 40-year-olds that are having the onset of this. Okay, and I know I'm in my 40s and I've got 4 kids, 2 of them are small, got to get them to school, got to get them, dinner. So that's going to have a huge impact on people who are still in that younger ages. Okay, but what might change that priority? If they're closer to here, maybe it's not coping, maybe it's gas exchange. So depending on what's going on with your patient will depend on how those priorities change. I want you to take time and think about that as you're getting ready to care for patients, and think about the MS patients that you have had, because there's so many out there and they're in such different stages of the illness. So take some time and come up with your own priority concept map for these patients and dig into the why. Why did I put this as my first priority? Because that is thinking like a nurse.